Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And we had some shows talking about new procedures and orthopedic surgery and things of that nature. And a lot of folks asked questions relative to how long rehab is and how long does it take to recover, et cetera, et cetera. Well, I decided I was going to bring some people forward who could talk to us about what we call rapid recovery. So we have two experts here. Sitting in front of me is Dr. Eric Schiffman. He's an orthopedic surgeon and basically highly skilled and highly trained. Okay, because the reason I know that is because one of your mentors was Dr. H. Thomas Temple, who is now the Executive Vice President for Research here at Nova Southeastern University.
Right.
So
I trained under him and essentially started my medical school in New York, did residency down at Miami, did a fellowship in Boston, primarily in hip and knee replacements, and then after a couple years working in Ohio, got smart and came back to South Florida where this is now home. So I've been here 2 years doing primarily hip and knee replacements, and I got acquainted with Dr. Katz at Westside Regional Hospital, and we really worked together to try to implement something called rapid recovery for our total joint patients.
Dr. Jonathan Katz, who is you're the medical director at the Department of Anesthesia, not only at Westside Regional, but I know you have multiple responsibilities with the Sheridan Corporation, correct?
Correct.
So welcome.
Thank you.
Good to have you here.
Thank you very much.
You've been the Sheridan Corporation has been a longtime friend of Nova Southeastern University, but more importantly, now with our new relationships with Westside Regional, we're very proud to have both of you here. But tell me, Dr. Katz, tell me what's going on in the field of anesthesia, because I know we're going to talk to Dr. Schiffman about the Schiffman cocktail, but you tell me what's new relative to rapid recovery.
For sure. So about 8 years ago, I arrived at Westside Regional, where we had a very robust orthopedic joint replacement program. And with everything, as a young person coming in new into the practice, I identified there were some opportunities that existed. You know, never be comfortable with the status quo, always wanting to do a little bit better. How can we make some real changes and real improvements? And it started off with how are our patients doing in the recovery room? Post-operatively, we would see our patients and, you know, with the various medications we're using, how are they doing overall? Is there any way that we can make this experience better for them? At that point, we made some adaptations to our practice based on the best available evidence in the literature. And we really took it from that point and said, well, if we're worried about how our patients are doing, why are we confining it to this time period of 1 hour after the operation? Let's talk about the whole process. And then it went from, well, wait, now we're going to talk about the process, but we're not talking about just after. Because this really is a process that is initiated from the very beginning. And it starts actually weeks before the patient comes to the operating room. It comes about 3 or 4 weeks in advance, where we discuss with the patient expectations with regard to pain management, physical therapy, rehab. What are we going to want them to do? We want the experience overall to be very positive. Many years ago, total joint replacement was a tough operation. Patients would be in the hospital for 5 to 7 days. There were a lot of side effects because of the medications, for the pain management, because pain management was one of the major issues, nausea, vomiting, delirium, a number of things that prevented patients from going home. We took that understanding and we said, well, can we avoid those medications? Is there anything we can create or do now, knowing what we know in the literature, that can make it a better experience? And so with Dr. Schiffman's help and collaboration in our facility, we were able to create a process, again, that starts 3 weeks before for education and expectations and goes all the way out. Now we confined it to 2 days, but we really condensed it for 5 to 7 days to a stay that should be somewhere less than 3 days now. And that's what our goal is. And again, appropriately, wanting to limit the time the patients spend in the hospital for their benefit. Be there as long as you need to, but we want to get you out so you can get back to the way of life that you want to get to, which is the reason you had the joint replacement.
Well, you know, the wonderment of healthcare today is the speed of what I would call efficient change. It isn't just change for change's sake. It isn't change because there's a new technique or a new knowledge base. it's really, it incorporates the nature of the patient's needs. And it's always, listen, every doctor has always worked for the patient. We know that. And it goes back to the Hippocratic Oath. So I'm now going to turn it over to Dr. Schiffman, who's going to talk about not only the Schiffman cocktail, but this collaboration.
Right, so just a couple interesting points is, you always read in the literature that hip and knee replacement has been one of the most successful surgeries of the 20th century. But the number one reason why people don't elect to have a hip or knee replacement is fear of pain. And that's well proven in many different articles. So one of the issues that Dr. Katz addressed is looking at the literature, finding what the problem is, and coming up with a solution. In the early 90s, the average length of stay in the hospital was about 8 days. You had a knee replacement, you would stay there over a week, and mainly you were on a pain pump. If anyone of the audience has had surgery, they remember the pain pump that they would push. Didn't really work well, caused a lot of nausea. 10 years later, the length of stay has been cut by more than a half. It's now less than 3 days, and the reason is improvements in pain management. My patients will ask me all the time, what's the biggest change in your practice in hip and knee replacement world? And there's implants, there's techniques, but really number one thing is pain management, our understanding of pain, controlling it, which leads us to the whole rapid recovery process.
Well, you know, the interesting thing about that is, and we've talked about this on prior shows over the last couple of few years, and that is the recognition by the healthcare community, the medical hospital community, and the adoption of the 1 through 10 pain scale. I mean, if you think, I mean, I know you guys are young bucks compared to me, but you know, I can tell you that, you know, for the few times that I was hospitalized, the question never came to how do you feel, or you know what. But with all due respect, and I had wonderful doctors, but on the asking that question about where your pain is at, I think is oversimplistically a wonderful tool for the patient to communicate with professionals such as yourselves to provide for pain management.
Right.
Correct?
It's a fifth vital sign, they say now.
Right.
So it's something that, you know, my first question when I walk in the morning is, how's your pain? What can we do to make it better? And most people, they say they have no pain or it's very tolerable, especially coming from where they were preoperatively. They came in with pain. Now they're experiencing a different pain, but it's much more tolerable.
So tell me about the Schiffman cocktail.
So I just found out the name of it this morning. So
okay.
I didn't patent or quote that, but basically it's a combination of different medications. We use what's called a multimodal technique throughout the whole process. It starts with preemptive analgesia, which means we give medications to stop the pain before it starts. And that includes pills that are given in the preoperative holding area. We have our anesthesia colleagues do nerve blocks. The idea is also to stop the pain before it starts. At the time of surgery, I use this cocktail, which I guess is now called the Schiffman cocktail, which is a combination of different medications that we give around the knee at the time of surgery or the hip to help control the pain, help reduce blood loss, and decrease inflammation.
And not to give away any secrets, but I mean, are we talking about what the folks out there normally would see as written prescription products, class 2 products?
No, it's actually, it's a great question. It's not, no narcotics are in this cocktail. The cocktail is composed of some local numbing medicine, like the dentist uses, an anti-inflammatory, and then some medicines that work synergistically with these medications to help make them last a little bit longer and stay where we want it to stay.
So you use products that take and localize the use of the product to that particular area, correct?
Correct.
Not much different than, by the way, you mentioned the point, like in the dental practice, one would offer an anesthetic, but usually there's epinephrine involved, which prevents it from going beyond a certain area. In other words, it tries to prevent it from going beyond a certain area. So that's in essence what you're talking about.
Correct. There's epinephrine in the cocktail to help keep it where we want it to go. It also helps reduce some of the blood loss after the surgery because epinephrine constricts the vessels. And then we use ropivacaine, Toradol, which is a strong anti-inflammatory, and then clonidine, which helps potentiate those medications.
Dr. Katz, talk to us about your colleague, Dr. Schiffman, because you observe him. He's there. I would assume that you have one of these new, when I say improved ORs, you know, they're multifaceted, multimodal, I guess you could say, individual capabilities, not only for the orthopedic physician, but if he needs someone else in there, they're adaptable for that. But tell me, you as the anesthesiologist, or you as the person who is talking to your anesthesiologist to work with Dr. Schiffman, tell me what their role is.
Yeah, so the great thing about the pathway that we created from start to finish is that whether it's me or one of my colleagues, we are interchangeable in that scenario, because we wanted consistency. That was the most important thing with this whole process. If you're going to create something, again, you don't want to have 9 different ways of doing this. We want to have a very similar way, tailored, of course, to the individual scenarios that are required for the patient. But by and large, we wanted to create that consistency. And so with Dr. Schiffman, we created this process again from start to finish using the multimodal pain approach. And then whether it's me or one of my colleagues, we're all going to proceed in the same fashion. Now there can be deviations certainly that are patient specific, but by and large we're able to, you know, from a general standpoint, all function in an interchangeable fashion. And to me, that was really the secret to the success of this, because the collaboration and the cooperation amongst the group in anesthesia really helped to facilitate and really solidify our results post-operatively for outcomes.
Well, you know, again, we did a show recently on cardiovascular intervention, and it's really interesting because, you know, even there, people don't think of the anesthesiologist as part of that situation unless there's a reason to do what we traditionally call open heart, I guess you could say operative procedures, but today that's been limited. Oh, I shouldn't say limited. It has been decreased because of stents and because of interventional radiology and things that have prevented I shouldn't say prevent, have diminished the number of open heart procedures. But the anesthesiologist plays an incredible role in that. Right. Because they, and again, I'm going to use unsophisticated terms, but as I understand it, the anesthesiologist tries to keep the patient as low with anesthesia or the application of anesthesia as possible, because the interventional cardiologist needs that patient to be, I would guess you could say, sometimes in a semi-conscious state. Correct?
Right. And I think that brings to the point really in anesthesia, one of my big focuses where I'm at Westside is to get involved with as much as we can in patient care. When this process started with the orthopedic pathway, there were some comments made as to why is the chief of anesthesia at the table talking to us about case management, disposition, where we're going post-operatively? Because this is what matters for patient care, that's why. Because for process improvement and improvements in patient care, you have to be at the table having these discussions. And in my mind, it's a great opportunity because there was so much we could accomplish and so much improvement we could make. And we saw that with implementation of our pathway. Overnight, within a month, we saw our length of stay reduced by a full day with this pathway that was implemented. An amazing change that you would think, you know, one length of stay, the cost of that in a hospital, reduced right off the top just by implementing our process.
Well, and again, as the viewers, because a lot of these reasons we have these programs are because the viewers ask certain questions. But it's very interesting because it's the application of Dr. Schiffman's capabilities as an orthopedic surgeon combined with the efficiency of your anesthesia application, and then going back to Dr. Schiffman again with his Schiffman cocktail, starting early on, pre-op, dealing with the patient in order to bring about what I offered in the very beginning, the efficiency in healthcare. Okay. Healthcare has become not necessarily efficient just because you want to reduce the costs. It's really to give less trauma to these people out here who fear, again, I tell you over and over again, the two things that we hear the most about from our viewers. They always are talking to us about minimally invasive techniques They're always talking to us about pain and blood and cutting, all right? Now, that's not very sophisticated, but here it is. I mean, you know, you all are trained to deal with that, but that's what they think about and what we're trying to do. And what you have accomplished at Westside Regional is by reducing the number of days, you're reducing the anxiety that a patient would have before the procedure.
And along with the reduction of length of stay, there's a lot of other things that have come along with it. Improved patient satisfaction, less complications. In addition to just controlling pain, what Dr. Katz was alluding to, he's helped change our blood transfusion protocol. Our transfusion rate has dropped significantly, so there's less chance of needing blood, better patient's satisfaction, they're in less pain, they're able to do more, they're happier. And that, in addition to having good pain control, that allows them to get out earlier, which, again, once the patients are home, they're more comfortable, they do better, and studies have shown that.
Well, you know, the interesting thing is just a couple of days ago, we have a very active physical therapy program here at Nova Southeastern, which is part of our College of Healthcare Sciences, and they work hand in glove with our College of Medicine because we have sports medicine and rehab medicine in the same locale. And it's amazing to me to see the difference, I mean, observing, not as a physician, but observing the attitude of the individuals who are showing up for rehab. Mm-hmm. I mean, they're almost happy to show up for rehab because, number one, they no longer have significant pain. They know that they weren't in a hospital for these long periods of time. And to be candid, they're very happy with their doctors, mm-hmm. which is really, you know, I know everybody likes to be loved, but what I'm saying is if they begin to understand that what you are doing is for their behalf,
right,
it makes the whole situation a lot easier. Right, Dr. Katz?
Absolutely. And I think one of the best things I see is when a patient will come in who had a total joint replacement 10 years ago. And I can see the hesitation on their face when we're talking about it. And some will ask, some will not. But we're very proactive about discussing the entire procedure and the expectations with pain. And they'll say to me after, are you sure I'm going to go home in 2 days or 3 days? Are you sure my pain's going to be well controlled? Because last time it wasn't. And I said, I got it. We're going to take care of this. We're going to make sure you're doing great. We want you to be the best shape you can be so you can get back to the way of life that you want to be in. And that's what this process we created. We had to adapt from the way we were 10 years ago. Medicine can't stay that way. It needs to evolve, and that's what we've done at Westside to improve that experience. And the best thing I hear is when those patients go and see Dr. Schiffman in his office, I can't believe how great this was. The first time I had this done was nothing like that. And to me, that's a real success.
I just had that 2 days ago. The gentleman had one knee replaced 4 years ago. I did his other one 2 days ago, and he couldn't believe when he woke up that he didn't have pain. He didn't have a pump. I haven't used a pain pump in over 5 years. He took minimum narcotics, and he was walking the same day as surgery. And he was shocked. And then he was asking me if he can go home, which I said, yeah, absolutely. There's really no indication to keep you because medically everything looks good. Your pain is controlled. We send him home.
Well, it's interesting because I was visiting last week with a very dear friend of mine from my hometown, the center of the universe, Brooklyn, New York. and what happens is that he was telling me that he had a knee replacement 12 years ago. And he now has to have the other knee done. I said, how come you didn't? What, didn't they consider both knees at the same time? He says, yeah. He says, but they told me at that time, and this was in New York, they told him that, oh, the pain's going to be so significant that you might want to just consider doing one at a time. Well, it isn't necessary to do that anymore.
No,
correct?
Absolutely not. And 12 years ago, I mean, you would have been in the hospital probably 2 weeks.
Right.
Now, even when we do these bilaterals, which is both sides at the same time, maybe 2-3 days in the hospital. Patients are going home. If we're doing the hips, there's an approach that we use that has made it even easier for patients to get around independently, even right after surgery. So we'll do bilateral hips if the patient so desires. Mm. And they're walking around right away.
Let me ask you a question. In preparation, obviously, in anesthesia, there's always a lot of preparation. There's always discussion with the patients long before they even get to the area where they're checked into the hospital. I know anesthesia practices have changed, I think, for the better. Mm-hmm. Not that they were bad before, but I think for the better. I think there's more communication with the patient. The less anxiety they have, the less trauma they have relative to their procedure. But before you intend to do a hip or knee or whatever joint replacement, sometimes you have people that have conditions. They're obese. They're physically, I would say, underperforming mm-hmm. relative to their activities and otherwise. Do I assume that you get involved in some of that pre-thought process of selecting to do a joint replacement?
100%. I mean, that is something that falls directly onto me. That's my responsibility. I'm kind of the gatekeeper. Yeah, you could look at an x-ray and say a patient needs a knee replacement, but you can't operate on an x-ray. You have to operate on a patient. I've seen some x-rays where terrible arthritis and a patient is living very well, and I don't recommend surgery. And at the same time, I'll see someone with bad knees, but she's 300 pounds overweight, and it makes the surgery, the risks of the surgery far outweigh the benefits, and I won't do the surgery, nor do I recommend anyone else do it. I'll put them on regimented weight loss. If I find something else wrong during their workup, if their blood count is low, I'll have them get optimized to try to reduce the need for a blood transfusion. There's a lot that we can catch early on to prevent complications from happening later. The biggest complication or our biggest fear is an infection. And if you actually look, the amount of procedures we're doing per year is going up. We're doing close to 1 million joint replacements in the US per year, but the infection rate is also going up, which is surprising. And it may be that we're not doing as good of a job of screening these patients as we should be. So patients that are obese, we shouldn't be doing certain procedures if they're over a certain body mass index, which is their height divided by their weight. Studies have shown that their infection rate goes up. So instead of saying, well, the surgery is surgery and this is your risks, we could decrease those risks. If you get your blood sugars in better control, if you're a diabetic, get them under a certain value, improve the outcomes. So I think it's our job as orthopedic surgeons to be the gatekeepers as far as who should be going for surgery and who we need to optimize beforehand. And whether it takes 6 months or a year, it's worth it because we want to reduce the complications.
Well, not only that, but obviously we're having anesthesia here in Dr. Katz's hands. You really have, healthcare today is a team effort. There's so much today that you have the privilege of, in being in a sophisticated tertiary care institution like Westside Regional, you really need to, and you have already stated, you really need to work with the patient, but working with the patient doesn't only mean working with the patient. It means working with your colleagues who have been caring for that patient, whether it's an OB/GYN, whether it's a family doc, whether it's an internal medicine doc, whether it's a cardiovascular doc, whatever. Is that true?
Absolutely is. In fact, one of the things that we worked on at Westside early on was the development of a pre-anesthesia process where we develop guidelines and the patient flow through to optimize the patients, ensure optimization. For this to be successful, what we've identified is we can do all these modalities, multimodal pain management, blood utilization, and minimizing transfusion, minimizing anesthetics because of regional anesthesia, other things. But if the patient doesn't come in the right state, we may not get where we want to be for the patient's sake. So we found that there are a number of things that we can get at pre-operatively, and that's really why we start this process 3 or 4 weeks in advance, identifying risk factors. What can we do to optimize the patient? Again, with the cardiologist, with the primary care doctor, maybe with the endocrinologist in the setting of diabetes. Really give these patients the best chance for success. But developing that process was key first, and then the collaboration and cooperation after that really is what's led to the success of this as well.
Well, that's great. We're down to the last 4 minutes of this show. So I just want to get in one additional thing, and that is, number one, Dr. Shipman, where is your office?
I have 2 offices. One is in Plantation, right behind Westside, and the other one is down in Aventura, right behind the hospital off of Biscayne.
So are they in the MOBs, medical buildings?
Correct.
directly affiliated with the hospitals?
Correct. Yep. Both
Right.
are directly affiliated with the hospital. I operate out of both of those hospitals.
Right.
Do my joint replacements both at Westside and Aventura.
Okay. And of course, Dr. Katz, you're sort of tethered, I know, because you have incredible responsibilities as the medical director, and you're the regional medical director, actually, for Sheridan, I believe. And you deal with all of the HCA hospitals, I believe, the ones that you are involved with, correct?
In North Broward, right. So I'm involved actively with the anesthesia operations at the 4 facilities in North Broward, Plantation, University, Northwest and West Side. So, you know, we've developed processes as well to extend out to those facilities.
Well, you know, I just hope that everybody knows that when they go into the OR at one of these hospitals, if unfortunately or fortunately you do, that you got somebody like Dr. Katz overseeing things, which is important. So I want to thank both of you.
Thank you very much.
Not only for your work, but you all are going to be around a long time, and this is a pretty nice place of the country to live in. I think it's a very exciting time for healthcare. So I congratulate you, Dr. Schiffman, and trying to mitigate as much trauma to the patient, but giving them good outcomes, which is the most important thing. And to you, Jonathan Katz, MD, Regional Medical Director, or Department of Anesthesia. Oh, you got all kinds of things there. But I want to thank you, because a lot of people without knowledge of anesthesia, they fear a lot of things. I know we had a show, oversimplistic thing about colonoscopies, and you know, and until they understood how easy it was to get involved in doing these things to protect themselves, and really, when it really got down to it, the one thing that you always hear is, boy, that anesthesiologist was great. So anyway, that's what you're attached to. So I thank you very, very much for your service and for your oversight. And like I said, I want to thank Sheridan Health for all of their involvement here at Nova Southeastern. They were certainly helpful for us in our Pioneer program. So I appreciate both of you for being here. You both work at Westside Regional Hospital, which is in Plantation. And we want to thank you and the people that you work with for the service that they give to the people out here. So once again, folks, if you have any questions or you want some answers to anything that was brought up, there's an email address and a telephone number right here, because you got to take good care of yourself. If you don't take good care of yourself, it just is not going to work. So take good care of yourself. This show is called Dateline Health. We come to you from Nova Southeastern University. And until next time, my name is Fred Lipman. See you.